Hello, everyone. So we're going to start chapter 2, talking about different developmental characteristics and congenital anomalies. So a couple of notes here. The developmental process, there's some outline here for you, involves fertilization and conception. The prenatal stages consist of embryonic, which is the initial 2 months of gestation, so the first 2 months of pregnancy, and then also fetal, which is the remainder of gestation until birth. So hopefully that's about another 7 months. So at any point in this prenatal development during the birth process, which is the perinatal period, or during the neonatal and postnatal periods, the development may diverge from normal. It may deviate. It may not go as planned. That happens quite frequently with pregnancies. And sometimes that generates a developmental dilemma. There's a table I would like for you to check out in your textbook. It's table 2.1 on page 44, and that will help describe some of the specific stages of development during this important period of life. So perinatal, again, is during the birth process, and then postnatal or neonatal is up to 1 month after birth. Congenital anomalies can be mental or physical. They may be present at birth or they may be diagnosed later. So a note here that I put in that I would like for you to know that these are present at birth, but they may not be detected until later in infancy or childhood. Some congenital anomalies aren't detected until a child goes through puberty. So, I mean, it can be years, 10, 15 years before a congenital anomaly is detected. And it is something that has been underlying since birth. So not all of them are as noticeable as we would like them to be up front. Limbs or organs may be malformed, duplicated, or they could be entirely absent. Causes can be genetic or non-genetic, or it could be both. So some non-genetic causes include infection in the mother, drugs taken by the mother, the age of the mother, radiographic examination that was made early in pregnancy. So if for whatever reason the mom had an x-ray done or some other type of radiology study done and wasn't aware that she was pregnant, that can cause some non-genetic birth defects or anomalies. Or any injury to the pregnant woman or to the fetus. So everybody kind of has some type of knowledge of the effects that drugs taken by the mother can have on an unborn baby. But I have seen some of those effects firsthand, and they are pretty substantial. So a lot of times babies, if they're fortunate, are only born addicted. And I say that in the loosest sense of the term when I use fortunate. So many of them, I have seen babies whose mothers used drugs during their pregnancy who are missing the majority of their cranium. So there's lots of ways that birth defects can come about and not actually be genetic. So when we're dealing with these anomalies, the team approach is going to be ideal, including medical assessments by physicians and appropriate therapy. So I put a note in here also that I would like for you to know. Again, everything that is in red is extra material that I have added into the lectures that I would like for you to know. So prenatal care and advanced surgical techniques have greatly improved the management of anomalies that are compatible with life. And what that means is if there's a good chance that a kid could live with the congenital anomaly that they were born with, then technology has improved in such a manner that it enhances the child's life and the possibility of them surviving several of the more common anomalies. So genetic disorders and syndromes they're forms of congenital anomalies, and they usually result in an abnormal gene taking up residence on one of the 22 pairs of non-sex chromosomes. So when a gene is on autosomes, it's called an autosomal inherited condition, and this can result from both dominant or recessive traits. So that's important to remember. Some extra points here for you. Genetic information is contained in microscopic thread-like structures in the nucleus of the human body cells. And take you back to biology, high school biology. Most people know that DNA, RNA, mRNA, all of that is located within the nucleus of the cell, and the whole entire human body is made up of different types of cells. So you have DNA and chromosomes in all of those cells, and sometimes there's mutated cells and that causes disorders and syndromes. So the parent who carries the abnormal gene has a 50% chance of transmitting the defective gene to each of his or her offspring. So that's a, half and half. It could happen, could not happen. When the condition is considered as autosomal recessive inheritance, the parent's abnormal genetic makeup must have genetic errors on both of the genes of the pair, resulting in the carrier usually having no symptoms of the disorder. Which means that the parent who is a carrier for that disorder is unlikely to have symptoms, however, their child will. So sometimes parents have a kid with a genetic anomaly or disorder or syndrome, and they aren't sure where it came from because they are fine. And turns out that, it ended up catching up with their child. So sometimes that's a bit of a struggle for parents. So we're going to talk about methods of prenatal diagnosis. The first is amniocentesis, and that's where we take amniotic fluid samples between 15 and 18 weeks of pregnancy. Those numbers, 15 and 18 weeks, are important. We only take amnios between 15 and 18 weeks if at all possible. And that's going to test the cells for chromosomal abnormalities or the presence of abnormal substances. So an example is an abnormal substance is something called an AFP, an elevated alpha-fetoprotein level. And that usually is a good indicator of whether or not the baby will have or have a higher risk of being born with Down syndrome. Amniocentesis is not without risk to the mother and the baby. An alternative procedure called chorionic villus biopsy, or CVB, can be performed in the second month of pregnancy. So let me give you a little bit of background about these AFP tests and amnios and all of this business. Usually, if there is concern, like, for example, a mother's age, if her age is a concern for risk for the baby to have Down syndrome, they will sometimes offer the mom the option of having these tests done. The thing is that 15 to 18 weeks in most states is over the time period or the gestational age that is the requirement for termination of a pregnancy. So I say all that to say that sometimes moms are on the fence about whether or not they want to know. And the truth of it is that oftentimes, even if they do know, they may not be able to make a decision to terminate a pregnancy based on the results of that AFP test. So adoption obviously is still a possibility for them, but if they're on the fence about having these very expensive, very painful, very invasive tests, and they're planning on using the results of that test to determine whether or not it is appropriate for them to terminate their pregnancy, then it's good to let them know that depending on state laws in the state that they reside in, that it may be a possibility that they couldn't do that anyhow. So some moms just opt not to do it and just, find out when the baby's born. Okay, so the second method of prenatal diagnosis is ultrasound, and we identify the spine and skull abnormalities with ultrasound early in pregnancy, which is a good thing. Many, but not all, congenital disorders can be detected through prenatal diagnosis, and the diagnosis of potential genetic or neural tube deficit disorders may provide the future parents with time to obtain counseling and to prepare for the many health needs of the infant before the child's birth. So there is an upside to having things diagnosed prior to the baby coming, because people, it's much like grieving, where your whole world kind of is upside down, and now you have to figure out what your next steps are. And so giving time to parents while the baby is still baking in there sometimes is helpful for them to, make adjustments to their life and to their care plan for the impending birth of their child. So next we are going to talk about conjoined twins. And conjoined twins result when separation process of identical twins fails to complete. So conjoined twins basically result when the separation process of identical twins fails to complete before the 13th day after fertilization. So that's the key there. They may be joined at different body locations and could share various organs. There are different types of conjoined twins, and those are listed for you here. And depending on the site of Pegas or where they're joined, they may be separated surgically. So if you Google images of conjoined twins, there's all kinds of different conjoined twin stories that you can read. Some of them have happy endings, some of them are kind of sad though, so just kind of be aware of that. Prematurity is a big deal for newborn babies. If they're born premature, they have kind of an uphill battle for the first several months of their life. So basically, a premature baby is a baby that's born before 37 weeks gestation. Typically have low birth weight. It's the leading cause of death in the neonatal period. They typically have an incomplete development of organ systems. Lungs are one of the last things to form and to develop fully in the baby, and so oftentimes babies who are born premature have a great deal of difficulty breathing and may need to be ventilated or put in an oxygen tent if they're breathing kind of okay on their own but just have low O2 sat levels. So just something to know. High-risk infants for serious health problems. So if they're born premature, they are already at a high risk for additional serious health problems. So the condition of prematurity describes the birth of a low-weight, underdeveloped, and short gestation infant. These infants are at a greater risk than full-term infants for developing serious health problems, including cerebral palsy, mental retardation, chronic lung disease, GI problems, vision and hearing loss, and also other multi-system developmental delays. Signs and symptoms of prematurity include little subcutaneous fat, palms and soles with a few creases, undescended male testes, prominent female clitoris. They lack the ability to suck or swallow, which makes feeding very difficult. They often have underdeveloped lungs and an immature neurologic system. The immature neurologic system can lead to some difficulties in maintenance of body temperature, problems in controlling cardiac function, spontaneous episodes of apnea where they stop breathing, or seizure activity. An immature immune system also makes the risk of infection very high for these babies. And since they're already compromised, a compromised immune system just adds insult to injury. It makes it very difficult for them to recover from many diseases that for a healthy full-term baby may not be such a big deal. So the pregnant patient who is more than 3 weeks before her due date and thinks she's in labor must be assessed as quickly as possible. Sometimes they'll give her some pharmacological agents to try to counteract her labor and stop the progress. So the etiology of prematurity, causes of premature labor resulting in a premature infant are an incompetent cervix, bicornuate uterus, toxic conditions, maternal infection, or trauma. So any of those things can be a cause for prematurity. Also a premature rupture of the amniotic membranes, an intrauterine fetal growth retardation, and other physical conditions of the mother. So that intrauterine fetal growth retardation basically means that the baby's growth is stunted while it's still developing in the uterus. There are many reasons that these infants enter the world before reaching the traditionally accepted gestational age of 40 weeks, and thus they have very low birth weights. Attempts may be made to halt premature labor by having the mother on complete bed rest or using drug therapy to slow or halt contractions. Neonates diagnosed as small for gestational age are low-weight infants that weigh less than 5 pounds 8 ounces, so less than 5.5 pounds, who may or may not be premature. So it could be a 40-week baby and weigh 5.5 pounds and be considered low-weight infant. Treatment for prematurity involves IV fluids and hyperalimentation, so they encourage the baby to eat a lot to encourage growth and development. Treatment varies depending on the gestational age, weight, and present or subsequent conditions, anomalies, and nutritional status. Airway management and pulmonary functioning are monitored. Recent advances in respiratory care for tiny premature infants permit extubation of the infant and maintenance of the airway by continuous positive airway pressure, which is called a CPAP machine. Some of you may know about those CPAP machines if you have sleep apnea, and that goes through the nose. So pulse oximeters monitor oxygen saturation and heart rate, and body temperature is going to be monitored and maintained. While when infection is a risk due to maternal prenatal infection or extended time of ruptured amniotic sac, vigilance is required for the onset of any symptoms of infection, and antibiotics are often started presumptively. So basically what happens is if the mom's water breaks way too early and it throws her into premature labor, the longer her water is broken, the more increased the risk for the baby to develop an infection becomes. And so sometimes they will start a mom on antibiotics presumptively to help try to prevent the baby from becoming infected. And sometimes when the baby's born and the amniotic sac has been broken for quite some time, they will put the baby on antibiotics without even checking or confirming, I guess, clinically confirming whether or not the baby has an active infection, just as a preemptive strike to prevent any further damage. Prognosis and prevention. Prognosis is going to vary depending on the gestational age, weight, and the occurrence of anomalies. There are some risks here, risk of a cerebral bleed, underdevelopment of pulmonary system. Like I said, lungs are one of the last things to develop in the baby, and they get really strong in those last few weeks. So lungs and the pulmonary system are always going to be a big deal for preemie babies. The accepted gestational age is 24 weeks. So I put some notes in here that I thought were interesting though. There are documented cases of 12-ounce and or 22-week gestational babies surviving. So yeah, you heard and read that right. A 12-ounce baby survived, and one that was at 22 weeks gestation survived. They fall, though, into the 1% of premature babies born at that weight and gestational age. So very few babies that are born before 24 weeks or born that small survive. Preventing prematurity requires good prenatal care, adequate nutrition, and assessment for the mom. So anything, things like abstaining from consuming alcohol and smoking cigarettes helps to reduce the risk of premature birth and or low birth weight. Additionally, bed rest of the expectant mother may delay the onset of premature labor and create more time for the fetus to develop. So a lot of times if they have a mom that's high risk pregnancy, they will put her on bed rest for the last several weeks of her pregnancy. In fact, I have a friend of mine who was on bed rest for 28 weeks. So, I mean, that was the majority of her pregnancy, but she was high risk. So they were trying to prevent her from going into labor early and developing and delivering a premature infant. Okay, so the next condition we're going to talk about is infant respiratory distress syndrome. That's IRDS or ERDS. Sometimes people will call it ERDS, but IRDS is the abbreviation. IRDS or hyaline membrane disease is also known as sometimes, is similar to adult respiratory distress syndrome in that the patient suffers acute hypoxemia caused by infiltrates within the alveoli. So the alveoli are these little sacs in your lungs, and they're down on the cellular level of your lungs, and that's where your gas exchange occurs. So your carbon dioxide is switched out with your oxygen down in those little alveolar sacs. So those guys are kind of important. They're small, but they are definitely mighty. So a neonate is going to exhibit signs of respiratory distress, including nasal flaring, like they are trying to take in extra air through their nose, grunting respirations, and sternal retractions, and then they become cyanotic. So they're taking in deep breaths, and you can see their little rib cage pop up because they're taking in such deep breaths, and then they start to turn blue, which is a surefire sign of pulmonary distress. So the NICU staff is going to observe the infant for signs of respiratory distress, and immediate intervention is instituted the first signs of distress. We do not mess around with babies who can't breathe right. The first indications of IRDS are an increased respiratory efforts of the newborn and a history of prematurity. The etiology for IRDS includes lungs of the neonate that lack surfactant needed to allow the alveoli to expand. So the way that this works is this surfactant is kind of like a lubricant. And the lubricant allows those alveoli to stay pliable. And then when the baby breathes in, it allows those alveolar sacs to expand and let that gas exchange occur. So if they have no surfactant, then their lung tissue becomes stiff and rigid instead of pliable and expandable. So blood gas studies demonstrate the reduced potential for adequate gas exchange, which of course is a big problem because that's where the hypoxemia comes into play. All right, so Nope, did I go too far? Nope, here we go. So treatment for IRDS includes administration of carefully titrated supplemental oxygen. And basically what that means is they very carefully increase or decrease the concentration of oxygen. So they may start at 100% oxygen and eventually wean them off of the oxygen or titrate the dose down so that the babies end up being on room air. It's usually administered by mechanical ventilation and positive end expiratory pressure. Aerosol infusion of surfactant allows alveoli to expand. So the prognosis for these infants' survival has improved greatly because of a better understanding of their condition and advanced technology in drug and respiratory therapy. Years ago, this was a big factor in mortality for infants, and so thanks to new technology, we have many more surviving babies. Prevention is always the best treatment. Parents may need emotional support and understanding, and they should be referred to community support groups if they would like. Laryngomalacia, Tracheomalacia, and Bronchomalacia. So Laryngomalacia, Tracheomalacia, and Bronchomalacia are all forms of obstructive airway conditions. They can evolve as separate conditions or as combinations of one another. The primary cause is softened or underdeveloped cartilage, which allows the airway structure to collapse. So your trachea is and larynx and bronchial tubes are all made of rings of cartilage, very rigid cartilage that holds the airway open. And so when those soften, they collapse and then create an obstruction or a blockage in the airflow, and that causes big problems for baby. Signs and symptoms in infants include respiratory stridor, which is a type of breathing sound, dyspnea, and possibly cyanosis. So diagnostic studies include chest radiographs, computed tomography, which are CT scans, flexible fiber optic laryngoscopy, and bronchoscopies. Treatment is going to be based on the underlying cause after it's been determined. BPD is bronchopulmonary dysplasia. It's a serious chronic lung disease that results after an insult to the neonate's lungs. The lungs are stiff, they are obstructed, and they're hard to ventilate. These babies appear to be working very hard to breathe, and they exhibit poor posture of the neck, which means they don't hold their neck up very well. Also, they have poor posture of the shoulders and the upper body. They sometimes have wet or crackling sounds that are going to be heard on auscultation of the lungs with a stethoscope. The infant experiences periods of dyspnea, including tachypnea, wheezing, cyanosis, nasal flaring, and sternal retractions, coughing, and difficulty feeding. The NICU staff observes the infant for signs of the respiratory distress, and immediate intervention is instituted at the first signs of distress. Radiographs of the chest are abnormal for these babies, indicating alveolar damage, either scarring or overinflation, sometimes described as a ground glass appearance. It occurs in many premature infants after IRDS, mechanical ventilation with supplemental oxygen, and infection or pneumonia. The goal of treatment for BPD is to replace the damaged alveoli. So supplemental oxygen and adequate nutritional support are going to be offered. That supplemental oxygen therapy may be needed for several weeks, occasionally for more than a year. As the infant grows and matures, blood oxygen saturation levels may be maintained on room air, usually around the age of 1. Diuretics can reduce the fluid accumulation in the lungs and the incidence of pulmonary hypertension. So adequate nutrition is needed for the infant's growth and to meet the increased caloric demand resulting from breathing. I meant to put that up here, sorry about that. Prognosis is good for these babies with early and aggressive intervention, prudent monitoring, and maintenance of adequate oxygen saturation levels and heart rate. There currently, unfortunately, is no way to prevent BPD. However, early weaning from mechanical respiratory support may reduce its incidence. ROP is retinopathy of prematurity. Retrolental fibroplasia is an abnormal growth of the blood vessels in the retinas of the infant's eyes. So this occurs most often in infants born before 28 weeks gestation. There are screening examinations that are performed routinely on a premature infant weighing less than 1,500 grams or at a gestational age of less than 30 weeks. The infant then is going to be hospitalized and usually has a pretty good stay in a NICU. There are no visible symptoms of this disorder. but the entire retina is going to be visualized to determine the stages of development of the blood vessels. Vascularization of the retina begins at the central part of the eye as the vessels grow out. The incomplete vascularization of the retina is what causes this disorder. There are no specific risk factors. High supplemental oxygen concentrations are typically responsible for many of these incidences, and certain drugs that are given for immature lungs can also cause ROP. The most mild forms usually resolve without treatment, but a couple of notes that I put in that I would like for you to know. Recently, intense artificial lighting in the nursery or crib has been considered a risk factor for ROP as well. Other risk factors cited include seizures, mechanical ventilation, anemia, so low hemoglobin, blood transfusions, and multiple spells of apnea and bradycardia. Diagnosis is made with an ophthalmologist, or by an ophthalmologist, using an indirect ophthalmoscope and scleral depression to visualize the retina. Laser treatment to the area anterior to the vascular shunt eliminates abnormal vessels before they deposit enough scar tissue to cause retinal detachment. Unfortunately, as with many of these diseases and conditions, there is no way to prevent ROP in a premature infant. NEC is necrotizing enterocolitis. It's an acute inflammatory process caused by ischemic necrosis of the mucosal lining of the small intestine, large intestine, or both. The infant is hospitalized, usually in the NICU. It's a condition of premature infants or sick neonates that develops after birth. Symptoms include feeding intolerance, abdominal distension, bile-colored emesis, which is vomiting, diarrhea, and a tender abdomen. There's also expected to see blood in the stool, decreased or absent bowel sounds, lethargy, and inability to maintain a steady temperature. The etiology is unknown. It's thought to be a breakdown in normal defense systems of the GI tract, allowing normal flora of the GI tract to invade the intestinal mucosa. Diagnosis is going to be made by way of blood and stool cultures that will be performed. In addition to prematurity, factors that may predispose infants to NEC include hypovolemia, sepsis, umbilical catheters, exchange transfusions, and IRDS. So observation of changes in the infant's feeding patterns or activity level, impaired body temperature maintenance, and respiratory difficulties, along with abdominal distension and tenderness, definitely call for further investigations. If the baby is bloated looking, has trouble breathing, can't maintain a normal body temperature, then you definitely want to get the baby back in and have the baby checked out, because part of their GI tract could be dying. So treatment includes aggressive and immediate intervention. Feedings are stopped and a tube is placed into the stomach. Fluids and antibiotics are going to be administered by IV. Respiratory status and pH are going to be monitored by ABGs, which are arterial blood gases. And then we're going to watch their weight, intake, output, and abdomen also. Radiographic monitoring of the intestinal tract is also going to be performed, so we'll do some x-rays, CT scans, MRIs if we need to. Complications of intestinal perforation or peritonitis require surgical intervention with the removal of the necrotic tissue. The tissue is dead, so we have to get it out of there. Without immediate and aggressive intervention, many of these babies will die. NEC is a very serious complication of prematurity, and some of these babies die even with the aggressive treatment that's provided to them. Most of these babies are still in the hospital when NEC develops. So it's bad to have NEC, but the fact that most of them are still in the hospital when it develops allows immediate treatment and aggressive treatment. So, I mean, that's kind of a good thing. Robinow syndrome is a condition of small stature and related incidence of interorbital distance, bulging or bossing of the forehead, a depressed nasal bridge, malaligned teeth, and short limbs. It may be present in dominant or recessive forms. There's a box 2-1 on page 57 that provides typical manifestations of this syndrome, so you can check that out. Characteristics may be mild to moderate, and people have found to be of normal intelligence, but they may have physical developmental issues. The clinical picture of short stature and presence of some of the characteristic signs and symptoms help the physician make the diagnosis for Robinow syndrome, so just kind of keep that in mind. This is a genetic syndrome, and the responsible gene has not been established. If it's recessive, the mutated gene is located typically in chromosome 9q22. Diagnosis is going to be confirmed by a genetic study indicating the chromosomal defect. Treatment is to address any treatable conditions such as dental abnormalities, those malaligned teeth, a cleft palate, or orthopedic conditions including scoliosis. Genetic and psychosocial counseling may also be recommended for these patients. So in early life, many of these children are misdiagnosed as being infants or children who exhibit a failure to thrive, and that's not the case. They have the syndrome, but they are often diagnosed as having failure to thrive. There's no cure for this condition, but with supportive treatment, individuals with Robinow syndrome can generally experience a normal lifespan. Cat's cry syndrome is Cri-du-Chat syndrome. It involves deleted genetic material from chromosome 5, usually results in a stillborn child or death soon after birth. Microcephaly with brain tissue deficiency is commonly present. Surviving children, so babies that have Cat's cry syndrome that survive typically have slow growth, small head, poor muscle tone, and mental retardation. Unfortunately, there is no cure, and supportive care, there's no prevention for this, so if it's happening, it's happening. Generally, parents are very anxious to discuss why the syndrome is present in their child and the possibility of subsequent children also having the syndrome. So we may need to refer them to a genetic counselor or to appropriate support groups. Hypertrophic cardiomyopathy is abbreviated as HCM. It's a congenital disorder that occurs when a portion of the heart muscle thickens without any apparent cause. Typically, when in a healthy individual, when the heart muscle thickens, there is an underlying factor, either environmental or meaning, social habits, environmental things that they were exposed to, or diet or anything like that. But with these kids, it's a congenital disorder, so they've had it since birth, and their heart muscle thickens, and they really have no reason why. They have no idea why the heart muscle is thickened. This is a scary thing because it's a major cause of sudden cardiac death in young athletes. Tragically, the first sign is the collapse of a seemingly healthy young athlete. So what you have is, and I'm sure everybody has heard or read a news headline about this at least once in the last few years, because there have been several of these kids that have HCM that have died. You'll have a kid that's in the middle of a basketball game, and he's been an athletic kid his whole entire life, and then all of a sudden he collapses on the floor in the middle of a basketball game and never recovers. And that's what typically we're talking about, is this HCM. So even though that kid had a congenital disorder, which means that his heart has been thickening up over time, his parents never would have had any reason to suspect that he would have a heart condition because he was a very healthy, active young man. So it's a very surprising very surprising reality to learn that their child had a congenital heart condition, because they never ever would have suspected that. So symptoms are going to include chest pain, syncope, hypertension, palpitations, or shortness of breath. So that hypertension deal, you're not going to find high blood pressure in a kid very often that has HCM. And the reason for that is people assume that because the child is very healthy and athletic and very active, that there's no way the kid would have high blood pressure. So they very rarely check blood pressure on these kids in a regular manner. They may get it done once a school year at their school physical, but other than that, they don't have a whole lot of reason to assume that they need to be monitoring blood pressure, which could be a symptom of this. It is possible that some individuals, though, experience no symptoms at all. Signs may be discovered during a physical exam. If you're lucky, they'll be discovered during a physical examination. So the diagnosis for HCM is going to be made on autopsy. The presence of life-threatening arrhythmias could be recorded on a Holter monitor if the patient is alive. So if the patient survives the the symptoms of this, they could be on a Holter monitor. Should the thickening obstruct the flow of blood, a surgical myectomy will be performed. ECG or EKG and MRI may indicate hypertrophy. Medications, including beta blockers and calcium channel blockers, may also be prescribed. Again, that's for the kids who survive an attack or who are discovered to have this condition prior to them collapsing. So patients should avoid strenuous exercise in stressful situations. The prognosis of the young person who has collapsed is very guarded because most are not responsible to immediate cardiac resuscitation. So if a point has come where the person has collapsed, we don't tell parents that we think it will be okay. We do not tell parents that there's a good prognosis for that child because oftentimes CPR does not resuscitate them. There is, scarily, very scarily, no prevention for this genetic disorder. Okay, so Down syndrome affects the heart defect, is associated with heart defects and other congenital abnormalities. The infant has a small head with a flat back skull, a characteristic slant to the eyes, a flat nasal bridge, small low-set ears, a small mouth with a protruding tongue, and small weak muscles. Infants with Down syndrome have an extra chromosome, number 21. A couple of notes here on Down syndrome for you. Down syndrome is a genetic syndrome where the individual has 47 chromosomes instead of the usual 46. This results in a congenital form of mild to severe mental retardation that is accompanied by characteristic facial features and distinctive physical abnormalities. Down syndrome usually is diagnosed prenatally via ultrasound, blood test, and/or amniocentesis, or during the neonatal period. Infants with severe Down syndrome usually are identified at or before birth, and then the milder forms sometimes are diagnosed later. Treatment includes care of the child. This is going to depend on the severity of the physical defects and degree of mental impairment. A treatment plan is an individual and includes the multidimensional approach to maximize the development of motor and mental skills. There is no cure for Down syndrome. Life expectancy has been improved through surgical correction of cardiac defects that are often associated with Down syndrome, and also antibiotic therapy for susceptibility to pulmonary disease. There is no prevention for Down syndrome.